everyone. This is your girl, Ashley Michelle, and welcome to the Ladies Room. As usual, I have my co-host with me. We have Mrs. Cannon Hill, looking so lovely today. We have Mrs. Understanding. Mrs. Jovo will be joining us later, but we have two very, very special guests that we are ecstatic to have with us. We have Dr. Kerri Lockhart.
Hello.
And we have Dr. Erika Taylor. And
hey, good evening.
I'm so excited to have you ladies. Thank you so much for joining us.
Thank you for having me.
You're
Happy to be here.
Thank you, guys. Thank you. So here in the ladies' room, we discuss everything pertaining to ladies, everything from dating and marriage and child rearing. We talk about societal issues. We talk about mental health. We talk about career. We talk about so many different things. And today we are talking about breast cancer. You all may know that 1 in 8 women get breast cancer in their lifetime, and so it's more common than we probably can conceptualize, and it's very life-changing and obviously can be deadly for people. So it's something that I wanted to talk about. And I hope that you all get something from this show. Okay. So today, Dr. Lockhart will share her personal experience with breast cancer. And just to give you a little bit of information about Dr. Kerri Lockhart, she is a West Side Chicago native. She was born and raised near Humboldt Park. She attended the prestigious Illinois Mathematics and Science Academy, also called IMSA, in Aurora, Illinois. She went on to study at Northwestern University, where she majored in psychology. She later obtained a medical degree from Southern Illinois, and she matched at Rush Hospital, where she worked as a resident doctor for 4.5 years.
Loyola. Yeah.
Loyola. I'm sorry.
Yeah.
Loyola. Yeah. I'm so sorry.
Yeah.
So, and while there, you served as a pediatric, is that where you also served as the pediatric department's diversity and equity inclusion committee?
That was at Rush. Yeah. So at Rush. Yeah, you're right.
That was at Rush. So she was a resident doctor at Loyola, and then she went on to work at Rush, where she also served as a DE&I committee chair. She was the recipient of the 2021 Excellence in Humanism Award and voted the 2021 Outstanding Medical Student Educator. Okay, Dr. Lockhart is a board-certified pediatrician, and she is also a fellow of the American Academy of Pediatrics. She's vice president of the Cook County Physicians Association. She holds a leading diversity, equity, and inclusion certification through Northwestern University, and she's also a member of Delta Sigma Theta. So all the Greeks out there, double team. Dr. Lockhart currently serves as a physician at Lodestar. Did I say that correctly? Dr. Lockhart?
Yeah, you did.
Okay, I couldn't see you for a second. And she does a lot of equity work that she can talk a little bit about later. I am also proud to say that she is my first cousin. She is here to speak with us about her personal story dealing with breast cancer. All right, so welcome, Dr.
Thank you.
All right, we also have another very special guest. Her name is Dr. Erika Taylor. She is a medical director for congregate settings at the Chicago Department of Public Health. Prior to joining CDPH, she worked as an obstetrician and gynecologist and associate program director at Mercy Hospital and the Medical Center in Chicago. She is passionate about health and wellness, advocacy, international health, and eliminating the persistent healthcare chasm that exists in marginalized communities. Dr. Taylor received her Bachelor of Arts in Pre-Medicine and Biology from Augustana College in Rock Island, Illinois. Prior to medical school, she worked in social services, serving juveniles and adults impacted by the justice system. All right. Dr. Taylor is board certified in help me say this, obstetrics. How do you say that?
Obstetrics and gynecology.
I'm sorry. I'm
No worries.
I can't see today. In gynecology, and holds a Master of Science in Preventive Medicine with an emphasis on epidemiology from the University of Iowa. All right, so welcome, Dr. Erika Taylor. Dr. Erika E. Taylor, thank you all. Sorry about that. That was a little rough. It's been a long day. I can hardly see. All right.
Give yourself grace.
Yeah, absolutely.
Thank you. So I'm very excited to have you all here. So as I said, Dr. Lockhart is here to share her personal story. And so we're going to get right into that right now. So you, I know that Mrs. Cannon, you had a question for her. You want to start us off? Or would you like me to start?
You can start.
Okay. All right. So, Dr. Lockhart, I just wanted you to start with telling us about when you found out that you were diagnosed with breast cancer and what were your initial reactions?
Yeah. So I think, I'm coming up, I think 12 years ago now. So it's been a while. I was an intern. So my first year of residency. So for folks who aren't sure what that is, once you finish medical school, it's 4 years, then you are a physician, but your training to be a physician is probably one of the toughest times on the path to becoming a physician. Because you're training and you're like learning a lot, and your intern year, you're new. So you are the doctor, taking care of patients. And so I was in my intern year and I finished the first half of that year. And oddly enough, I had found a lump that summer, though, right after I finished medical school. And I was traveling and couldn't sleep and hadn't done a breast exam. I had been really good about breast exams before that, and kind of fell off when this really, recommendation I didn't love about doing breast exams at home came out, that they didn't recommend people do breast exams at home anymore. And so I used that, even though I didn't love it, that recommendation came out, I used it as an opportunity to kind of be lazy about it. So I was not doing breast exams as regularly. And for some reason, I decided to do one when I was traveling after med school graduation. And then I found this weird lump area. And I always describe it as a lump, but it wasn't really a lump. It was like this just firm, weird area. And I had done enough to know that it was strange. So that was about beginning of June of 2010. And saw my doctor and was in between medical school and starting residency. So for like 2 weeks, I was uninsured and just wanted to wait until I started residency, and my insurance kicked in right away. And she said, that's fine. I just think you should see a breast surgeon just to be sure. I started residency and completely forgot about it. Completely forgot. And, there's a running joke that doctors are the worst patients. And I'm typically not like that. Like if it's something serious, I'm, or concerning, I'll go, for small things, I'll blow that off. But something concerning, I'm like on it. And so for me to forget about it, that just kind of demonstrates how much residency just kind of, you just get thrown in and you're kind of sucked in there. So it would be November when it would come back up again when I was establishing with a primary care physician. And she found it. And I still remember that moment she's like, is this new? And I really forgot about the lump, everything. I was like, yeah, for like a second. And then I was like, wait, no, I found this back in the summer and I completely forgot I was supposed to see a breast surgeon. From there, things went pretty quickly. And I still am not sure if they were being helpful because I was a resident, my time was limited, or if they were concerned. I don't know. And it was like mid-November. By the end of November, I had 2 ultrasounds and a mammogram, and they were all inconclusive, but there was something abnormal there. And November December sometime. Towards the end of December, I got a biopsy. When I got the mammogram is probably when I first got worried. I was like, I'm 33. I don't have breast cancer. Like, it didn't even cross my mind. And I'd had some benign breast issues before, and I was just like, it's probably just that. And I'm glad they're being thorough. But when I had to get a mammogram, that got me concerned. And I remember that was the first time I asked them, is it cancer? And they were like, we don't know. So December 30th, I got the biopsy. And they asked me if it was okay to call with the results. And I was like, yeah, sure, that's fine. I lived in the city at the time, and I was gonna head home after I'd been in the hospital all day working. And I don't know, I wasn't worried, but I was worried enough that I said, I probably shouldn't go home, because if I get bad news, I don't want to be by myself. And so I stopped at my sister's house that was close to the hospital and waited there for the news. And they called, and I remember still being pretty yeah, they're just going to tell me this is nothing. And I was sitting across from my sister, and they told me, that they were sorry that it was breast cancer. And I remember my smile went away. My sister was looking at me, and I started to cry, and she started to cry, and then called my mom. And she's like, I just remember, I don't remember. I don't remember everything they said after that. I remember her saying that it was DCIS, which we'll talk about a little bit later. But I got off the phone, and I remember saying to my sister, I don't want to die, because I didn't know. I didn't remember what I'd learned about breast cancer in that moment. And I was just thinking, I don't know, I waited so long, maybe it's spread, and I'm 33, I don't want to die. And so I was terrified.
So at that point, you didn't know much about the stage of where you were, correct? With breast cancer, you just knew you had it. You didn't know if you don't. Okay. Okay.
I have a question
too.
So
sure. Go ahead.
You said that they made a recommendation against doing at-home breast exams. Do you know, is that still the case? And do you know why?
I can talk.
I'll let Dr. Taylor say, because I'm not sure.
I can absolutely, I can speak to that. So the American College of Gynecologists, which is the governing body for OBGYNs, came out with this, I call it madness, basically stating that women should no longer do their own self-breast exams. This was probably maybe 5, 6, 7 years ago, maybe a little bit longer. And so really the thought is that, if a woman is examining her breast, the thought is that it's going to create more anxiety. If you find something and you're not really sure. However, I still believe that women should do their breast exams, just because many times it's that woman that finds it or their partner that finds the lump. And so that was something I would always do when I was practicing, OB-GYN. I would do a clinical breast exam when they would come in. And then I would also just still encourage them to do that once a month. And so I still am a big proponent of that.
Okay.
Yeah, so am I.
And what
for my teenagers, I would recommend it as well. So we start in pediatrics. We start teaching the pediatric patients to teenagers to start learning how to do breast exams. And the reason is because many women are I don't know what I'm feeling for. Well, you're feeling for normalcy, so you can know what's normal for you. And the reason I knew that was abnormal, because I had done so many for so many years. Even if I skipped a few months, when I did that breast exam, I knew that was not there. That had never been there, was not normal. And right away, I knew that was something I needed to get checked. And so if you do it every month, usually 2 weeks before or 2 weeks after your period, which ends up being the same time, that's when, you can correct me if I'm wrong, but the breasts are most calm, less lumpy, so to speak. You will get used to what is there, oh, these lumps are always there. And then when something pops up, you're like, that wasn't there before. And so we start pretty early teaching them how to do that in their exams when they're teenagers as pediatricians.
Okay.
And I would just add on, not just looking for lumps, but also looking at things like, has the skin changed? Do you have a texture? It's a French word called peau d'orange. So it looks like an orange peel. So looking for things like that when you have very advanced stages. Also, it's important to squeeze the nipple so that you can determine if there's any discharge. So if you're seeing things that are green, that it's bloody, if it's only coming from one breast, it's very important that you identify that and let your doctor know that, you know, you notice these issues. And then also pain. So if you have like pinpoint tenderness, like if you can just point to one particular spot and it's like, I have pain right here, and it's something that's a constant issue, then it's something also to definitely have evaluated.
I also learned that density of your breast might be an indicator that you have breast cancer. Can you all talk about that a little bit?
There's a thought that they're at increased risk because when you have really dense breasts, it makes it more difficult to actually get a really good mammogram. So I'm actually someone that has very dense breasts. And so it's ideally, you know, you should try to go to the same place every time so that they have something to compare it to. Sometimes I have to get like an ultrasound because it's like, okay, well, this doesn't look normal or what have you, but it's like that density just makes it more difficult. And especially if you have larger breasts too, sometimes it makes it more difficult to get an accurate reading. And even, you know, sometimes women can actually have a mammogram done and then still find a lump. So it's still important that, you know, the mammogram does not take the place of like having routine exams.
Okay. Now, so you have routine exams and you can still, some doctors may suggest you do your own, continue to do your own. What would be an indicator that, or the green light for going a step farther and getting a mammogram? Is it just your self-assessment at home?
So if there is a lump that's palpable, so a lump that you can actually feel, that's usually the first step in regards to going that next step to the mammogram. Also family history. So typically we'll say starting at age 40, we do the mammogram, but Dr. Lockhart is a perfect example of someone who was diagnosed much younger than age 40. And so, you know, if she were to have kids, her kids should actually start getting mammograms 10 years earlier than when she was diagnosed. So they would start in their 20s. And so it's really important, you know, to just not only just to have, if the lump is found, not only just to have the mammogram, but also you would have something called a diagnostic ultrasound, which allows us to see more of the breast tissue. And then the next step for like in Dr. Lockhart's case was a biopsy to determine if that lump is cancerous or not.
Okay. And when would you require an MRI?
So MRIs are done like for individuals that have breast implants.
Oh, I see. Okay.
But
there's a whole
they
list
did
of
an MRI for me.
Okay.
And I had very dense breast tissue, I should say. And because I don't know if this was why, but because I don't remember, because they did not identify the breast cancer fully on the mammogram for me. Like they saw abnormal tissue. So I don't want to give the impression that the mammogram was clear. The mammogram was abnormal. And they couldn't identify if that was cancer or if there was something else there, you know. And so this was well after they had diagnosed me with a biopsy. They wanted to make sure that the other side, my breast cancer was on the left side. They wanted to make sure that the right side was okay. And so I did an MRI, breast MRI. Subsequent to like my treatment and everything, we had alternating every 6 months where I would get for a period. No, actually up until last year, every 6 months I would get a mammogram alternating with a breast MRI. Because I have very, very dense breast tissue. And so they would use the mammogram to compare for changes and then the MRI for like a more detailed study. And so I don't know if the recommendations have changed more recently in terms of doing a breast MRI, but I got that. And I was younger when I was diagnosed. There was something about that as well.
Right. So can you tell me a little bit about, can you tell me, even as a physician, was there anything you did not know about breast cancer that shocked you?
I mean, really, I didn't.
One second, Dr. Lockhart. We actually have Mrs. Jovo. She's going to go ahead and join us. She's another host. Welcome, Jovo.
Hello. I'm loving all this information. I'm loving it.
All right. So Dr. Lockhart, so go ahead and tell us a little bit about just your experience, you know, some of the, I hate to say, I don't know if symptoms is the correct word, but some of the impacts on your body that you experienced. And was there anything that shocked you?
I mean, all of it was a shock because I'm a pediatrician. And so you learn some things about breast cancer, as a medical student. Like medical school is really teaching you a general, education about medicine. So you learn the basics. But like really getting to the nitty gritty, I didn't know. And so when, I think a lot of folks, when we're diagnosed with cancer of any type, that period between diagnosis and then when the treatment plan are one of the hardest, because you just don't have any answers yet. And so you don't know what's coming up, what's next. And I didn't have an idea of like, well, how fast is this moving? And so it felt like things were moving so slowly. So we, got the biopsy that was positive, and then I got diagnosed at one hospital, and then I moved my care because my primary care doctor was there. I moved my care to the hospital where I was a resident for ease and for financial reasons. That just was going to make more sense. And so I did that, they convened what's called a tumor board. And so a tumor board is like a multidisciplinary team that has like the radiation oncologist. That's the person who would decide if you get radiation. They have the oncologist, the person who decides if you are going to need chemo and what that would look like. They have the breast surgeon and a social worker, and all these people on the team who come together and look at your tumor and what's going on, and then decide what happens next. And so from there, based on, they agreed with the diagnosis, and DCIS is ductal carcinoma in situ. That means that you have a cancer that is confined to the duct. So if, for lack
and
of a
Dr.
better word,
Lockhart, can you explain? I don't know, maybe I missed that part, but the duct is from which, like, milk flows?
Yeah, when you're breastfeeding, where the milk comes from. So it's confined. And so if there's, I don't have a better way to describe it, but if you were forced to choose a breast cancer, it's the one that you would choose. It's described as stage 0. So you do surgery, and they said that at that point they recommended a lumpectomy. And based on I didn't know what happened after that. I'm like, well, do they take it out and then you do chemotherapy and radiation? I had no idea. Well, they have to decide if you're a candidate for that. It depends on the size of the tumor, and then something called the genetics of the tumor. So even if the tumor hasn't spread, and that was a really tough point for me, because my understanding was that what they had said to me was that, if your tumor hasn't spread, then we don't need to do chemo. So how they determine that is they take the tumor out, but then they take lymph nodes, what they call your sentinel lymph nodes. They've done study after study after study that shows that if cancer has spread, they will be in what's called those first lymph nodes that drain in your armpits. And so they will just take those out first. And if those are negative, then they know that it hasn't spread. And so that's how they do staging for how far it's spread. And then they grade the tumor for how abnormal it is.
Okay.
And then look at the genetics of the tumor. If it has certain markers on it, then that tells you how much risk you have for it returning. So I find out that it hadn't spread. There was what they call microinvasion, but nothing significant. My sentinel lymph nodes, which are the first ones, were negative. The tumor markers hadn't come back yet, but I did not remember that conversation. So when I went for my follow-up, I was like, oh yes, no chemo. When she says there's no sentinel lymph, those were negative. And then she's like, so we still have to wait for the genetics and find out if you need chemo. And I was like, wait, what? And so I was panicked. When I got home, to be frank, I was pissed off, because I'm like, I thought we were, I didn't get mad at the doctor. I got mad at home.
So, because you don't need chemo unless it's spread, right?
No, you could need chemo if it's spread, or if your tumor markers show that it is high risk for recurrence.
Got you. And
that's what I thought. I thought you didn't need chemo if it hadn't spread. And so that was a surprise to me.
Okay.
And then there was this whole other issue with the BRCA gene testing because I was young and I didn't really have any major risk factors, no strong family history, nothing. They, obviously I was 33, they wanted to do BRCA gene testing. And so I knew, that, and I remembered what went along with that, but my brain, I think, just didn't want to think about it. And so if your BRCA gene test, the BRCA gene is a gene that if you have that gene, there's 1 and 2, and I think they've found some other ones out. You have Dr. Taylor talk a little bit more about that. But at the time when I got diagnosed, there were 2 main ones. And if you tested positive for that gene, they knew without, with certainty that you would develop breast cancer and ovarian cancer. So the solution for that was a double mastectomy and removal of your ovaries preemptively to prevent that.
Mm-hmm. I
was 33, and I remember that genetics visit, and I had gone by myself, and not because nobody would go with me. I was like, no, I can go, and I wasn't expecting that. And then when I left, I remember calling my mom, and I was like, I don't care what the test shows. I'm not doing that. I'm not doing any of it. I'm not getting a mastectomy. I'm not taking my ovaries out. Like, I'm 33. All I could think was like, one day my life was normal, and then now this cancer is like completely uprooting my entire life,
Wow.
And so as a physician, it was really helpful for me to recognize that reaction in myself, because, it's really tempting to be like, why are they being resistant? Like, they'll die, when you're talking to a patient. But like, when you're a healthy person, and, I'll be very honest, I had this view in life, like, I make fairly good choices. I don't, I drink rarely. I drink more now, but at that time, rarely drink. I've literally never done an illicit, like this idea of like, I'm making good choices. Why me? And then it's like, well, what, do you think somebody who isn't deserves this? No, why me? And so it was a real struggle to like recognize, well, if not you, then who? I mean, life is not fair. Things happen, and it's an opportunity to, navigate it, and I'm blessed I came out on the other side and can see I would never have chosen this off a shelf, let me be clear. But now that I've gone through it, to be able to see the blessing that I've been able to be to other people. So, so those 2 things were really shocking for me, and actually kind of traumatic at the time.
Okay. I imagine there was a spiritual journey that you went through. And so we're going to talk about that in a little bit. But
for sure.
I know Mrs. Understanding had a question for Dr. Taylor.
Yeah.
Hey, Dr. Taylor. I am personally so excited. Oh, when she was reading your bio, oh my gosh. I want to clap every time she read something. But my question is, what are the treatment options, and how do those options affect the patients?
So in regards to treatment options, which Dr. Lockhart alluded to, there's surgery, so something called a lumpectomy, where you would just remove that particular lump. And then there's the mastectomy, where you're removing the breast. And sometimes you're actually removing, lymph nodes and things of that nature. So individuals can develop something called lymphedema. So you can definitely have side effects of surgery. There are individuals that may decide to do implants after surgery. And so there's a risk of things like infection. And then with things like chemotherapy, we have the issue of things like hair loss of appetite, and things of that nature. And then like radiation can, like worst side effect could be things like burns to the skin and things of that nature, decreased libido. One of the other things that I think people don't talk about a lot is like when you're going through chemotherapy is that also having to protect individuals that are in your household. So having to like flush the toilet twice after you go to the bathroom. If you're having intercourse, using a condom with your partner. And so really, not only is the chemotherapy impacting the patient, but also family members as well.
Okay. So it's called a lump. What was that again? A lump.
Lumpectomy. So it's fancy word, ectomy, removal of a lump. So
yeah.
Okay.
Yeah.
Why do
why
do you have to flush the toilet twice and use condoms?
Well, the thought is that chemotherapy can actually be transmitted to the partner. And so, or other individuals that are living in your household as well.
Oh, wow. Wow.
Yeah, I actually had a really good friend who went through, she had triple negative breast cancer. Dr. Lockhart kind of alluded to some of the receptors. So there's 3 primary receptors that can be found on breast cancer. So estrogen, progesterone, and there's another one called HER2/neu. And so in those individuals that have all of those negative, it's much harder to treat. And so it's very resistant to chemotherapy. And their outcomes are usually more grave compared to other individuals. They can treat it with chemotherapy, but therapies are constantly changing. And the thing about it is that that aggressive type of breast cancer seems to affect Black women and younger Black women. So I just think it's just so important that we, start to get those exams very early on and also have those conversations, because I feel like in Black families, we're always so hush hush about cancer. Grandma went to the hospital, she died, and no one ever talks about it. You bet not ask. And so really, we just need to start having those conversations about health and not being so private. So I'm just so happy that you're sharing your journey with us, Dr. Lockhart. It's definitely needed.
Thank you.
So, Dr. Taylor, what would I imagine every patient is a little bit different, right? So what would be cases where a patient wouldn't need chemo? Would it be just after the mastectomy and it hasn't, it's like what would be cases where that's like the last resort?
So really it would be an individual, let's say it's where the cancer is just localized to the breast. It's not affecting the lymph nodes and there's no spread. And so that would be a case where you could do like a lumpectomy on individuals, where it's called very, very early. So the thing about it is that we don't know, the stage and things like that when it's initially diagnosed. And so we have to undergo the surgery in order to do staging. And so, each patient is different.
Okay.
Yeah. The chemo, you want to think about that, treats cancer in the system. So cancer that's gotten out of the immediate location. Right. So if you have cancer that, has spread beyond the breast or, that has a very high risk of doing that, even though it hasn't yet, then the chemo is to get that and kill those rapidly dividing cells. Because that's really all cancer is, cells that have lost their ability to listen to the I think, what is it, P50 something? I can't even remember what it was.
P53.
P53 that kind of controls our cells from dividing out of control, and they've lost their controller, and so the chemotherapies kind of stop those.
Right. So the chemotherapy would only be used. I'm just trying to make sure I understand for myself. The chemotherapy would only really be used if it's moved from outside of the breast, not if it's.
Well, no, that, and if there is one in the breast that has a high risk of doing that. So like I said, those like genetic, I think there were genetic markers or something. I just remember they told me like, we need to look at your genetic makeup of your tumor. And if it,
and that would be like if it's the estrogen or the progesterone receptor. So if those things are present on the cancer, then they're targeted with chemotherapeutics.
Yeah, like I had a type of, I guess it's called chemo. I had tamoxifen. So my treatment included the lumpectomy. I had to get 2 because they have a certain inch from normal tissue to where the tumor was that has to be, that they know that they've got enough of the tumor. I didn't have that initially. We had to do another lumpectomy. I had radiation for every day for 6 weeks, and tamoxifen. Tamoxifen is an estrogen, anti-estrogen. So oddly enough, most, as Dr. Taylor said, there are 3 types of receptors on tumors. So think of a receptor as like a lock, and there's a key. So we have estrogen receptors on our uterus, on our breast and brain, all sorts of places. And then the hormone goes in there and activates things. Well, tumors have those receptors on there too, for whatever reason. And so you get estrogen on that tumor and it helps it grow. So then they can make medicines that block that. And so tamoxifen was an anti-estrogen to help any potential, micro tumors that got out, to stop those from growing. But I had really bad side effects to it. You're supposed to take it 5-year. Studies have shown that decreases the risk of recurrence. And I took it for 2, I think, 1.5, 2 years, and had I had hepatitis. When people think of hepatitis, they think of like getting an infection from someone, but you can get medicine-induced hepatitis. And my oncologist, who is a world-renowned oncologist, she was the head of the department, said she had never seen that before. And I was a resident again, and my liver enzymes doubled every day for like 3 days. And we're up in the hundreds. And it also worsened what was mild symptoms of ADHD that I had not been diagnosed with. And I subsequently ended up getting diagnosed because it worsened those symptoms and I could no longer accommodate on my own. So it changed my life.
Wow. Wow. I know Mrs. Jovo had a question for you, Dr. Taylor.
Yes, Dr. Taylor, what are some causes of breast cancer?
So, of course, genetics. So, of course, we can't choose our families. We can choose our friends. And so genetics is a key thing. You know, other risk factors would be, you know, obesity. So we're always talking about just, you know, that balance of diet and good nutrition, tobacco, which leads to all different types of cancers. Also, a term called nulliparity. So basically, if you've never had children, so if you haven't had any children by the age of 30, that increases your risk.
Really?
It does. If you had early, if you started your periods early, that increases your risk, or if you stop having periods late. And so really, you know, it's basically just looking at the estrogen levels. And so individuals who start their periods early, it's like you're exposed to estrogen for a very long time. And same thing for a woman who is menopausal after age 51. So average age of menopause is 51. For a woman continues to have periods after 51, you know, that thought is that they're, you know, have increased levels of estrogen. So they're also at an increased risk of cancer as well.
Okay. I wanted to also ask, what about women who have a history of like fibroids or like polycystic ovarian syndrome, things of that nature? Is there a connection between that and breast cancer as well?
There's no direct connection, but I would say more of an indirect connection, because typically, you know, the thought is that, you know, fibroids are more likely seen in definitely in Black women. If you were to put 10 of us in a room, probably 7 or 8 of us probably have had fibroids or had some issues with heavy menstrual bleeding. With PCOS or the polycystic ovarian syndrome, typically those individuals are going to be more obese. And so you're going to see, you know, again, that increasing your risk factor for cancer.
Wow. Okay. And you touched on this a little bit, Dr. Taylor, but can you give us some digestible, I guess, to-dos or digestible pieces of information that will help us have a healthy lifestyle and or diet that will help us prevent cancer?
Absolutely. So I won't say it won't completely prevent it, but you can reduce your cancer risk by staying active. So doing at least 30 minutes of activity 5 times a day, 5 times per week. So 150 minutes minimum of exercise per week is important. And you can always break that down. You can break it down into like 3 10-minute increments if you have a busy day, or park further back in the parking lot, take the stairs. And so really just, you know, take opportunity just to get more active. I think when you're going to the grocery store, shop the periphery, because when you go down the aisles and the Chips Ahoys and Oreos start calling your name. So really shopping like the periphery of the grocery store. So that's your fresh fruits, your veggies, your meats, and just hitting those items. I think, you know, things in moderation. I think, you know, really trying to limit things like, you know, your fried food. There's some thought that alcohol also increases your risk. So, you know, when you're having like 2 to 3 drinks or more daily. And so that can increase the risk of cancers as well. So in regards to diet, I think just finding that balance in regards to, I mean, you know, we all round up for the holidays. So I think just having that moderation where like maybe you're having a little bit of this and a little bit of that, but really trying to avoid things that are like fried and processed and things like that. And just trying to just do fresh fruits and vegetables. And that's a whole nother topic when we start getting into food insecurity in our neighborhoods, not having access to those things.
Yes. And both of you all do diversity and equity work, correct? Both of you do, right? To some degree?
I do indirectly.
Okay. And so we'll talk about that a little bit later. I definitely want to talk about that. We can't have this conversation without talking about that. But I have a quick question, and I know that Cannon has one as well. But I wanted to know if there's any truth to some of the things we hear about everyday products causing breast cancer, not just the foods we eat. For instance, I hear a lot about how deodorant causes cancer, or is it any type of cancer, or that's not true? Okay.
No, they did an extensive study to confirm that. And I think it was more recently, though, that the results came back. It was the aluminum in deodorant that was concerning, if that was contributing to breast cancer. And the study came back that there was no connection there. Am I right about that, Dr. Taylor?
I haven't seen that study, but I haven't seen that. Haven't had an opportunity to see that study.
Okay.
Yeah.
Someone has a question.
I want to say it was about 2 years ago.
Okay.
No, go ahead. Uh-oh.
She's frozen.
Oh, no, I was just saying, I think it was about 2 years ago.
Oh, okay. All right. And I want to address some other myths. Someone has a question in the chat, though. Titanium asks, are there any dietary changes that need to be made if someone is on radiation or chemo?
I didn't have any dietary changes on radiation. No, it makes you very tired, and it can affect your infection fighting cells, the white blood cells, but they didn't give me any dietary changes. I do know, and Dr. Taylor speak more to this, for some chemo regimens, you can't eat raw food because you're very at risk, almost guaranteed, that your white blood cells will be depleted, and so you won't have a real good immune system. And so like eating like lettuce even, I know anecdotally, when I was diagnosed in residency, I had a good friend who was also navigating another cancer diagnosis, and we would, commiserate around our diagnosis, and she was going through chemo and would microwave lettuce, because you couldn't eat that without, getting some, it's raw, and, so things like that. I don't know if there's more.
Okay. Thank you. Dr. Taylor, did you want to add on to that?
Nope, I have nothing to add.
Okay, thank you. I know that Mrs. Cannon had a question.
Yeah, for Dr. Taylor, like in your experience, what are some common misperceptions or that you've encountered regarding like breast cancer? The most common.
I would say one of the things is really around imaging. So individuals are very hesitant to get mammograms because they feel like the radiation from the mammogram can cause cancer. And so that's one huge myth that's out.
Mm-hmm.
Other myths is that, you can't get cancer if you don't have someone in your family that has it. And so really, just there are individuals who are sometimes diagnosed that have no family history, and, sometimes risk factors that we can't really identify.
Mm-hmm.
The other thing too is that men, and it's not really a myth, but like really that our men should also be getting examined and checking their breasts as well. Like Beyonce's dad was diagnosed a few years back. And so that's one of the other ones as well.
I was gonna ask that too. Oh yeah, about men. How common, like men in comparison to women, how common would you say that is that men are diagnosed with breast cancer in comparison to women?
It's much less. I don't have an exact number on it, but the thing about it is that the thing to be concerned about, if those men have daughters, that puts the daughter at a very, very high risk.
Oh, wow.
And so, but I don't have a percentage, but women, if we live to be 70, 1 in 8 of us will develop breast cancer.
Wow.
All right. Thank you for answering that. I actually was telling one of my coworkers today about the show, and he's like, well, and have them mention that men get breast cancer too.
Absolutely. Richard Roundtree, Shaft, for our older people that may be watching. Yeah, definitely.
Yeah. One stat that I came across was about 1 in 1,000, but you guys go and do your due diligence with that, because I did a quick Google search. It does say, according to the American Cancer Society, breast cancer is rare in men. Less than 1% of all breast cancer occurs in men. So less than 1% of all breast cancer occurs in men, but it's still very possible, right? And so anyway, so I just wanted to add that. Thank you all. I wanted to ask Dr. Lockhart a few questions about her experience. How did this affect other aspects of your life, like work and your dating life, your social life?
Dating. I wasn't dating much. I was like dating someone off and on at the time. So that didn't, I mean, because that person had been in my life for a while. So that was not changed much. I think work, it got actually more, it was helpful. Like I wanted to go to work. I think I took like a day off. Now, at the time, I'll be honest, I was very much of the, indoctrinated into the medicine mindset of, don't take a break, don't look like weak, and so I actually used to be very proud and, brag about how I only used a week of vacation for my first lumpectomy and a week for my second lumpectomy. And I would, go and get radiation before clinic, or if I was on call, that means you slept in the hospital for, it was my second year when I was doing radiation. So you were in the hospital 30 something hours, and I would wake up early, go get radiation, go back and round on the babies I was seeing, and, and finish the day. And so I absolutely don't recommend that, because I remember by the end of the year, I was very, very, frankly, I was depressed. It was the first time I had sought therapists in my life. And my doctor actually noticed it. She's my breast surgeon, who I still follow with, Dr. Claudia Perez. She's amazing. I started with her at Rush and at Loyola, and she's now at Rush. And she was like, I'm worried about you, because I was like really concerned about how everything looked. And surgeons are artists, and so they know when things like don't look optimal and when things look optimal. And the reality is, now 12 years later, like the work she did was great. But I was just like, so, it just was really having a hard time with like how this happened to me. And so that's where it really, really tested my faith. I mean, like I was angry at God, like, why did you let this happen to me? I don't do anything. And I know that it even was hard for some of my family, who's, my friends, who I call family, who were close to me, who felt the same way, like Kerri, like,
Yeah.
And I'm very much of the mindset, like, God can take it. It would be like your parent being mad at you because you're mad at them. And, God was still there, even though I was like, whatever, because I was really angry about it. And so I remember I couldn't pray for a long time. I couldn't read my Bible for a long time. I just was like, why would you do this to me? And then I had a friend who reached out to me, and his cousin had been diagnosed with breast cancer. I remember feeling very much like I didn't know any young Black women who were diagnosed, who could be my confidants. And there was Why Me was a big at the time. They subsequently got defunded, or didn't have money, and they disbanded. But that was my only kind of lifeline. It was a website and a message board, and any time of night you go there and there was someone, because it was around the world. And so I would really, communicate with them a lot, especially in the early days when I was having a tough time. And so when my friend reached out to me that his cousin had been diagnosed and she was really scared, he's like, I don't know how you're feeling about, supporting someone right now. It was at a time that I had some distance from it, and I was like gung ho. And that happened a lot. And so to be able to be that person for people that I didn't have, it really, I was happy to do that, because I didn't have that. And so I got to be able to support people and give them some idea about what they could expect. And, again, I would never choose this off a shelf. but because
Right.
I had it, it gave me an opportunity to, help guide people through it who, didn't have anybody. And so it was tough. It was really tough. And I connected with a really amazing psychologist at Loyola at the time who worked only in the cancer center, which was really helpful. And she really helped navigate me through through that. And so it was one of the toughest times in my life. Oddly enough, though, I've had tougher. It wasn't the toughest thing I've gone through.
Yeah. Yeah.
Puts things in perspective, but it also has informed the way I show up in my life now. I'm like, there's just certain things I will not stick around to tolerate or accept, that are harmful, spaces and things, because, any day I go back, the cancer could have been, they could have told me that it came back a year ago, though. And it was a little more than a year ago, December of 2019, I had a really, really terrible scare where my imaging 6 months apart was really abnormal on the right side where I didn't have breast cancer. And it was in December time. So it was the same, like tracking the same way when I was first diagnosed. And it ended up being benign, but they wanted to watch it closely. And after that, moment when she came in and said that it was fine, I remember breaking down crying, and I was like, I can't do this anymore. I cannot do this. At the time, it was 2 years ago, I'm 43. And if I live another 40 years, like this will happen again, and I'm done. And I decided at that point that I wanted a double mastectomy. But I wanted to make sure I wasn't making a choice in like duress. And so I waited 6 months, and I saw her for my follow-up, and she's like, how do you feel about that? I said, I still want it. So at the end of December 2020, I got a double mastectomy. And I'm so glad I did, because I don't have to worry about it. And so I think about that BRCA gene testing when I was like, I'm not doing that. I tell people it took me 10 years to get here, but it was the easiest choice I ever made. So now I don't have to worry about breast cancer anymore. So yeah,
it was worth the peace of mind, I guess. Yeah,
absolutely. It's actually the first time I publicly said that. I wasn't sure if I would.
I know I skipped that question because I know.
I know we talked about it. I wasn't sure, but I think it's really helpful for people to know that it's okay. It's okay. It's tissue. And it's just really been a lot of trouble tissue that I just don't need anymore. I just, this next half of my life, I want to aim for peace and health and wellness, and letting go of that.
Yeah. Mrs. Jovo had a question, so did Mrs. Understanding. Mrs. Jovo, you have a question about family?
Yes. So, and I actually have two questions, because I'm inspired by what you said about making the decision for the mastectomy. My first question is, how can families be supportive during this process? Like, what advice would you give to like family members in terms of the support that they can lend someone who's going through this experience?
Yeah, that's a good question, because I think there were certainly folks who meant well and did things that made it harder for me. The one big thing I think that sometimes asking and knowing that there's some days where we absolutely know what we want and need, and there's some days we won't, and being like comfortable with that, kind of change. I was having a really tough time, and I would have, some people who would just be like, well, you just got to pray and, be thankful that, you're still here. And so my response to that was like, well, if my comparison is like, well, you didn't die, it's not really like, and so I think recognizing, where we are and in our capacity to just hold space for people's just like their sadness and their pain. And sometimes we aren't, so we want to move into like fixing it and making them feel better. and really just sitting with it and saying like, yeah, I know this is hard and I'm sorry. I wish I could take, whatever that might be, but something genuine and not fixing it. At some point I got angry and I was like, I am praying. And I think that was when I got really angry and was just like, I'm done praying because that's not working, And so like, as a community, I think sometimes we think that if prayer's not working, that somehow that person is doing something wrong, or, if you don't lean just solely on prayer, or if you're not grateful, for everything, like God's going to be mad. And I'm always very much like, God can handle it. Chill out. God knows that I'm a human. And so I think for cancer, folks going through cancer survivors, like the emotions are all over the place. I would have some days where I was like really laughing and, jovial. And then the next day I, was really sad. And so asking what they need, what would be helpful. And if they aren't sure, sometimes just being with them. I remember the first night, my best friends were like, you want us to come over? And I was like, no, I just want to be alone. And then they showed up at my door with lactate and my favorite chocolate donut because I am lactose intolerant. And I was happy they came. So when people like really thinking about, what usually comforts them right now. And oftentimes that's not advice. They didn't come over and, tell me that it'll be okay, because we don't know if it'll be okay. They told me they would be there with me every step of the way, and they were. So and then like, the practical things, like if they are going through chemo, they can't cook, like they're really tired. And so sometimes setting up a meal train and making sure that those are taken care of, especially if they're single and living alone. And even if they aren't, the family, having someone at home with chemo is really overwhelming. And, sometimes people are so overwhelmed, they don't ask for help, or they're embarrassed about everything that's going on. And so, offering and saying, hey, I was going to set up this meal train, they would, bring, you can do money and they can order. So you can set up for the orders to come to the house for fast food, or, people can cook and say, I'm going to make lasagna and sign up, and, those kind of things. Cozy socks and blankets, especially if they're doing chemo, because when you go to chemo, you're there for a while. Sometimes people are really cold. They lose their hair. Comfortable hats. Usually the fleece ones are nice. And depending on what side effects they're having from chemo, asking if those things would be helpful. The night before I was getting my mastectomy, my friend surprised me and brought me this big bag of all these things, like they had gone and researched. And so you have drains and everything after you get the first, it's like a phase thing. And so they like thought of everything that I did not think of. And so they had like this thing for me to have my drains in. And so there are lots of different sites where you can go on and see like what things would be helpful for someone who's going to get a mastectomy, or someone who is going through breast cancer, and do things that like they are just too overwhelmed to even look at. And, make them a goodie basket, and then just staying in touch. Sometimes they're too tired to reach out, but sending a message and saying, you don't have to respond, but I'm here, and just checking in, because it's easy to kind of, when they're not available, forget. And then they, are just there at home by themselves. So,
Okay. All right. Well, thank you.
Helpful.
Thank you. I know Karen has a question, and then she actually has to leave. Mrs. Understanding has a question, and then we'll spend the next like 10 minutes talking about equity concerning breast cancer. Okay. So, Karen, what was your question?
Yeah, the question I want to ask, and this could be for either of you or both of you, because I know you mentioned something about the cost associated with some of the things that you had to do. What advice do either of you have for people out there who either may not have insurance, or if you do have insurance, what are some if this is in your wheelhouse at all, do you know if there's some specific things you want to make sure you have covered in your policies in order to make sure that you're getting the care that you need if you do run into this type of an issue?
I do know there, and Dr. Taylor will speak a little bit more to this. I admit I had tremendous amount of privilege. I was a resident at a hospital. And even with that, there were still some issues. I won't say the insurance because I don't want them, coming for you guys. But there was an insurance that everybody loves that gave me problems with, an aspect of my breast MRI and would fight me on it every year. And, I'm a resident, it wasn't a ton of money. I mean, when I say a ton, for some people, this is like, money to get to work every day, for the week. And the part that I didn't know how much it was going to be, but it ended up when they continued to do it. And then that one year they just refused. And it ended up being $100. So I was able to do that. So I have a lot of privilege, because of where I was. But it is my understanding that for breast cancer care, like the basics, insurances have to cover that. And Dr. Taylor, again, will speak to that. I know there are lots of organizations that will provide free mammograms and things like that. So, for example, the care for my double mastectomy, that is covered. And any reconstruction related to that is covered because it's all related to my breast cancer. So it's not like, oh, I want to get breast implants for like breast augmentation. This is a reconstruction. And there was a legitimate reason because there were subsequently abnormal findings on my imaging that wasn't cancer, but it was just like this imaging continues to be abnormal with new abnormal findings. And so it was justified. And so certainly connecting with those free mammogram, because then you can partner then to, if you need subsequent care, to get that. Nobody should be going without a mammogram. That just can't happen. Early detection saves lives. I mean, I don't know what would have happened, but it saved mine. Dr. Taylor.
All right.
And then just on the other side of the coin, in regards to free mammograms, here in the Chicago area, there's a program called Equal Hope, where you can actually get a free mammogram, also pap smears. And then it also follows you through if you end up needing treatment and things of that nature. So I'm not sure what's available in other states, because I think I was hearing a Southern Belle on here. But I would just consult with your physician. I think they can usually give you details in regards to what's available in other cities.
Okay. Equal Hope. I just put that in the chat for you guys. But thank you. I appreciate that information. I know that Cannon has to go now.
Yes, thank you, ladies. I'm gonna be close by though. I'm gonna continue to listen in. This is some excellent information, and I really appreciate you bringing your expertise, Dr. Taylor and Dr. Lockhart. I greatly appreciate you being willing to come on and share your story with us.
Thank you.
Thank you.
Thanks. Have a good night.
Good night.
All right. So I wanted to shift gears a little bit. I believe Raven has a question for you, one last question, and then we're going to switch gears just a little bit and spend the next 10 to 15 minutes, well, probably just about 10 minutes talking about equity as related to this topic, and then I'll open up the calls or take any calls that we get. Okay. So Raven, I know you had a question about just, for people who maybe a young woman out there or an older woman who's just heard news of her breast cancer. What was your question pertaining to that?
Just like Cannon said, you guys have been dropping excellent information. Everything has been on point. My mom had breast cancer about 5 or 6 years ago-ish. But like you said, it started off in the breast, and similar to you, she thought I could just work through this. It's just going to be benign. Nevertheless, it ended up in her lymph nodes. And similar to what Dr. Taylor was saying, it was estrogen. prone, I believe. But from then on, you know, she did do the mastectomy. It wasn't a double mastectomy, but you have been on point. You know, you've been right on it. So my question for you would be, what advice would you have for women who have just learned they have been diagnosed with breast cancer?
Is that for me?
So both of you.
Oh, okay. Yeah. I think it sounds so trite to say this, but it was the only thing I could do, really. And it's really all you can. It's not all you can do, but it's one of the most important things to do is you have to really try to take it one day at a time. When I remember when we were getting diagnosed, I mean, my brain is the best and worst place for me to be. A friend of mine brought me this cup. I don't know if you guys can see it. And that's what you do. You start thinking about, what I'm not going to be here a year from now. I'm not going to be, and certainly in those early days until you get the information, like you will drive yourself up a wall. And you spend so much, and that's what I did. I remember, and then I find out it's stage 0. I don't need chemo. And I spent weeks just crying every night and worrying about this. And am I going to die? Is it in my liver? Is it, And so really just trying to take things a day at a time and, working with, I remember when I started, even after I started my treatment and everything, the psychologist had even tried, it sounded like so ridiculous, but it worked. She said, why don't we try scheduling time to be sad? And I was like, what? But she said, pick a time, from 7 to 8 p.m., whatever it is, and stick to it.
Joho loves that.
Set an alarm and that's your time. And when it comes up before that, you remind yourself, nope, this is the time. I got to get work done. I got to do this. And so if that's what you have to do, no, I can't, this isn't my time to worry about this. I'm giving myself an hour to worry about the future, whatever related to my cancer, because the truth is you just don't know, until you get the information. And even when you get the information, I'm a scientist, but I'm also extremely hopeful, and so I remember they told me because of my age that when I did the tamoxifen, it could send me into menopause. And, that was a possibility. And I was just like, I'm just going to trust and not let that add that to the worry list. And so I think really trying to take it one day at a time and just chunk it, okay, this is our next thing. Working on that. We're doing that. Then what's the next step? And that's how I started to get through. And before I knew it, it was 1 year, it was 2 years. And cancer, you count things in 5 year. And I got to my 5-year event-free survival. And then I got to 6 and 7. And now I was talking to someone just recently. I was like, wait, it's been 10? It's like, no, it's been 12 years. And so that's the first thing I would say, just taking things one day at a time. And then, finding your team. My mom was a rock star. Like when I tell you, there's this article that talks about, I forget exactly what the premise was, but it works for it was about grief, and it's like a spiral circle. And it talks about grief when someone dies, for example, people go wrong and they'll come and say, oh, I'm so sad that your husband, and they're crying. And they're like, that's not how grief goes. You don't dump grief into the circle. You can dump to anybody outside of that ring. So there's a dot in the middle of the person who's experienced the grief. And then there's a circle around them. So they dump to anybody outside of those circles, but nobody can dump in. Right. And so it's the same thing. Somebody who maybe is diagnosed with cancer. So you can't come and dump your emotions into the person who's gotten cancer. They need the support. So you got to find somebody in a ring that's right outside of you, or any ring that goes outside, and finding that support so that you can be supportive to the person who's diagnosed, but you also have support to be restored so you can be, there for them. And so those are the two big things I think that are so important to me. My mom, like me, is very emotional. And I was just so proud of her and how she showed up for me. And she told me after the fact, she said, yeah, because when I get off the phone with you, I would go and call one of my sisters and cry to them. But I never wanted to be putting that burden on you to worry about me and care for me when you needed that support. So finding, gathering your support team who can do that. And then I'll give Dr. Taylor some time.
All right.
I think you summed it up. Those were some of the same points that I would have added, having that support team. I think the only other thing I would add is maybe just also seeking out a therapist. I don't know if you stated that earlier, but I think that that's just another good way to kind of help with this journey. And I think outlook is huge just in regards to, how you deal with the diagnosis. I think about my friend who was diagnosed with triple negative, and her entire mentality about it is like, I'm going to conquer this. So she's currently 5 years out, and she had the very aggressive form. So I think mindset is everything.
Wow. Mm-hmm. All right. Unfortunately, Mrs. Understanding stepped away just for a couple moments. She got a little, reflective and reminiscent of her mom, who experienced this. So she'll be back with us.
Absolutely.
But we do appreciate you guys a lot and all the information, because I know that this is helping a lot of people. But we have a caller and who has a question for you guys, or a comment, I'm not sure. Can you introduce yourself, please?
Hello.
Hi. Go ahead. You can introduce yourself.
Hi, my name is Edna Overton, and I have a question. It's more for my daughter. Can you hear me okay?
Mm-hmm.
It's more for my daughter. What would you say to a person who has breast cancer history on both sides of her family, and they decide, well, the best way for them to combat it is for them to go ahead, even though they've never been diagnosed, but have a double mastectomy to prevent it in case it is in the genes. What faces a person like that?
So first of all, I would want to know they should actually have the genetic testing done first before making that decision. And then it also depends on what relative is affected, because we look more so at what we call our first degree relative. So that means like mom, dad, or sister or brother. And so really you would need a little bit more information just in regards to who's diagnosed with the breast cancer, and have the genetic screening done first to be sure.
Okay.
And I would just add, I think sometimes
her grandmother on both sides of the family, her mom's side and her dad's side.
Okay, so that would be considered as secondary family members. And so again, the recommendation would be to have the testing done for genetics.
Okay.
Okay, very good. Thank you.
Okay,
I want to thank both you ladies.
Thank you.
Oh, Dr. Lockhart.
Very enlightening.
Oh, thank you. Thank you for watching. Dr. Lockhart, did you want to respond as well?
Yeah, I just wanted to add to, sometimes people are making decisions out of fear and not with the data that Dr. Taylor's talking about.
Right.
And so years ago, well before I was probably even born, like there was this kind of move to just like do mastectomies and not really recognize how, breasts are an important part of women's, appearance, and that's really important to some people, to most women, I think. And so now there's been a much more of a shift to not encourage that if it's not needed. And so if, we don't want people making decisions out of fear without like science behind it. And so, what Dr. Taylor said is so important, like get the actual scientific information, because it may not even be relevant. If they were 70 and were diagnosed with breast cancer, that's a little bit different, not that it doesn't matter, but then if they were both 33 and diagnosed with breast cancer. So.
Okay, so the genetics test would reveal what further information?
So that was that BRCA gene testing that I was speaking about, that tells you that the gene runs in your family. So we know that the risk of you developing breast cancer and ovarian cancer is a given. And breast cancer is, I don't remember the age. Dr. Taylor can, I don't know if you know that, but I think for ovarian cancer, it's a little bit later. And they recommend it at the time, it was around like 45 that you have the ovaries taken out. And I think the mastectomy is right away. And so you take those out prophylactically. So to prevent breast cancer and ovarian cancer from coming. So if she got the gene testing, then it would say, yeah, both your grandparents or one side, has the gene, and that's why they, both have you have a higher risk of breast cancer. And so we do recommend that you get a double mastectomy. But without, you don't have the positive gene, they would probably not recommend that and just recommend screening more regularly.
Okay. And Dr. Taylor, did you have something to add to that?
No, I don't.
Okay. All right. Well, that wraps us up. We did want to hear a little bit more about equity as related to this topic, but we're going to say goodbye to Dr. Taylor. I appreciate you so very much, very, very much. And is there anything you'd like to share about yourself? Do you want to share about your contact you, or because you're not practicing now, or anything that you like to share before you go?
Sure, absolutely. So you can actually follow me on Instagram at Dr. Erika 2.0, and I'm actually doing a Instagram live on Thursday nights. So it's every other Thursday. So we will actually be next Thursday at 6 p.m. Central Standard Time. Instagram Live at Chicago Department of Public Health Instagram Live. You can find me there. And so really just addressing some issues in regards to equity in the Black community here, health and wellness, and looking at some of the social determinants of health.
Okay.
But I'm gonna just say again, just thank you so much for the opportunity, and I would love to come back and be a guest again in the future.
Awesome. Thank you so much. I will be linking that. So the Instagram page, and you said what date was that again? What days?
It will be next Thursday.
Okay.
And it's every other Thursday at 6 p.m. Central Standard Time. I can send you the information.
Thank you. And I will share it in our Facebook group. For those of you who are watching, you can follow us on Facebook. We are called the Ladies Room Podcast Group Chat, and I will link all of that information for you guys, as well as put it in the chat. But thank you, Dr. Taylor.
Oh, you're so welcome. Have a great night, everyone.
All right. Bye-bye.
Okay, bye-bye.
All right. So we are going to segue into just talking a little bit about the work that Dr. Lockhart does with building equity in medicine. So can you tell us about that, what you've been up to?
Yeah, so it's been kind of a winding road a little bit. I went into medical school not really knowing that was exactly what it was called, health equity or anything like that, but I just knew that I wanted to make sure that people in my community were getting compassionate and competent care. After several experiences as a child with severe asthma, my mom had really severe asthma and was finally well controlled when she was partnered with the first Black doctor I ever saw in my life. And, I really include her in part of my story of being a doctor because she took an interest in me and brought me into her office. And, those experiences really helped shape the doctor that I am. And so I went into medicine for that and thought that being in clinic and working with patients in my community would be the way to achieve that health equity. And the more I did that, even as I moved into a leadership role, I did that for going into 3 years. I just started to realize that I didn't feel like I had as much of a reach and as broad of an effect on health equity as I wanted. And so I started to really think about what it would look like to expand my reach in health equity, how I could do that. And when we talk about health equity, we know that almost on every measure, Black, Latino, Latina, Latinx people, and Indigenous people are disproportionately affected by diagnosis, worsen outcomes, whether that's dying or having different side effects, not side effects, but like we call it morbidity. So some bad outcome, and just their treatment, not receiving optimal treatment, than white people. And for me, like, this is a fixable problem, and I just felt like I needed to be able to have a bigger effect on that. And so as I love patient care, I love connecting with families, but I felt like the best way that I could help do that would be not being a clinician at the bedside and building something that allowed me to go in and really work with institutions leadership and help them build equitable institutions. And so I'm in a transition because I just left clinical medicine barely 2 months ago. And so I'm in this transition point of building that out. And my work with Lodestar is some of that, because a lot of DEI work has to be done with this trauma-informed lens. And institutions have to come from that lens, because you can't do DE&I work if you don't understand trauma. And so that's kind of how I got into the space I'm in now.
Okay. Thank you. Mrs. Jova?
Yeah, I was going to ask how that was my second question earlier. How much is the connection between trauma-informed care and treatment to being an actual, breast cancer patient or a doctor that's providing care to someone with breast cancer? I know I'm an addictions counselor, so I have to be trained now on trauma-informed care. So I was wondering, has that urgency for trauma-informed treatment and care kind of flooded over into this area as well?
In medicine, you mean?
Yes. Mm-hmm. In medicine.
It's starting to, and I think not fast enough, but the pandemic certainly has kind of pushed the issue, because the reality is a lot of doctors have been really traumatized. We often call it burnout, but it's really trauma, by the experiences that they've had, during the pandemic. But this is really what we call, and you'll probably recognize this term, it's like acute on chronic burnout, right? People have been burning out for years, and then this, pandemic happened. And so I think there's certainly pockets that are really starting to recognize that, like, without really leading from a trauma-informed place, we cannot do DE&I work well. We can't do healthcare well. And my take is we cannot train residents, medical students, to be doctors well if we don't teach them how to be trauma informed, because everyone is coming in with some trauma, and this certainly in the culture we live in America. Right. So it's trickling, it's getting there, and we're certainly a loud bunch, so we hope to make sure that they hear us. So
okay,
a loud, nice bunch, but
all right, I have one more question, and then I'm going to close this out. What can a physician do, or anyone in healthcare do, to inform themselves of trauma, or get asked? I know they can't always inform themselves because they may not have the knowledge, but what can they do to seek out information and gain more capacity for addressing issues of trauma when, let's say, maybe they didn't get that type of training or education at a college or a university or at their place of work?
Yeah. So I think it really becomes, I am less optimistic when we put the responsibility on individuals. I think institutions have to take up the charge and say, and that's what they do all the time. Like when there were infections happening in the hospital for wounds or whatever, like There was what we call quality improvement measures that said we need to figure out why all these infections are happening and figure out a way to prevent that. And so if we recognize that being trauma informed is important, then we do a QI, potentially, but I don't know that we need to do a quality improvement measure to say that you need to be trauma informed. And so what that looks like to me is leadership having ongoing training, one that deals with the trauma of the physicians and nurses and healthcare workers in the system, because you can't really say you have to be trauma informed and do trauma informed patient care, but we're not going to address the trauma that we are inflicting on you. And so I think certainly if physicians want to seek that out on their own, many of the training that I've been doing in the past year has been physicians who are just, engaging in, training through, the place where I now work. And so you can do those training. There are ones all the time where you get to really spend some time like breaking it down. And so I would encourage that. I mean, it's when you see it, you can't unsee it. And I don't know how, some physicians do it naturally because it really starts from a place of being empathetic. But if you really care about being a great physician, then you're going to seek out ways to learn. Like we do continuing medical education all the time. We have to keep up our skills and things. And so an individual doctor can go and seek out the training, one that is CME accredited, so that they are getting that. And then institutions can really incorporate it into their system and say, we're going to make this part of something that we're training our leaders to do, but also our physicians and staff, so that we're all doing this every quarter or, twice a year, so that we are continuing to build a system that actually heals.
Okay. I actually do have one more question. I know I said that was going to be the last question, but I think this last question will be.
I could talk about this all night, and I do not want to keep you guys here all night. So
I want to make sure that Mrs. Jovo and Mrs. Understanding don't have anything that they wanted to add on to before I ask this last question. Okay. So my question is, as a patient, what are some indicators that a physician is trauma informed, or in other words, someone that is providing you quality care? Sometimes I feel like as patients, we don't know what's normal. I've been into a doctor's office, a couple doctor's offices, and I've wondered, well, is that routine? Is that something that, he or she would have done had I been someone else? I wasn't sure of how to measure it. I just know that I left feeling like perhaps I did not receive thorough treatment and service. So what would this trauma-informed care look like?
So the first thing I would say, trust that and feel very comfortable naming it. If you are with a physician and you are feeling like, I don't feel like what I'm here for is been addressed fully, I really want to encourage Black people to name that in the moment. I see these posts on Facebook that are like, if you've asked your doctor to do this and they won't do it, have them write it down in the chart. And those are just games that don't really get to the root of what we really want. We want people to give us the care that we deserve. And that's equitable. There's study after study after study. I was on a health equity summit yesterday, and literally basic things like there's a diagnosis called atrial fibrillation. One of the treatments is, I don't know the ins and outs of it. I'm not a cardiologist, but what I do know is that they put people on a blood thinner, anticoagulant.
Okay.
And literally a study that shows that Black people are not always being put on an anticoagulant. That is very basic. Like, how do you just not do the standard of care? And so if you go in and you're feeling that way, trauma informed looks like my ego does not get bruised when the patient says, I don't feel like what I came here for is being addressed thoroughly. The person who's not trauma informed gets offended and is like, I don't have time for this and blah, blah, blah. I'll tell you a quick story. I had a family that came in once, and they weren't patients who had seen me. They were patients of one of my colleagues. And, the discussion they had had with them was appropriate about, if this continues, they were like, we might consider doing something else, like imaging. They came to see me in like our urgent care clinic. And this kiddo had gotten better, but then the symptom returned. And so what all they'd heard was like, if this is going on, he needs, my kid needs to get this imaging. What my colleague really meant was like, if the same thing continues consistently for this amount of time, we might consider that. Versus what I saw was like, that thing continued, recovered, and now they have a similar thing that, and so I, talked to the family about it and, said, no, oh yeah, no, I don't think he needs that. And they got really upset and said to me, like, I just feel like you're blowing us off. And it could have been very easy to get defensive and get upset with them. I sat down, I was like standing at the bed checking the kiddo. I finished checking him and I sat down on the stool and this is like our urgent care. We're supposed to kind of get this done. It was on a weekend. Nope. And I took the time to kind of walk them through my thought process about, why I was making this decision so that they could understand it was not just a rash, blow off decision, get out of the office, I want to move on to the next person, that I was really thinking about his care and what was going on. It took me another maybe 5-10 minutes to do that. And when we finished that discussion, I remember that Dad said, thank you, Dr. Lockhart, for explaining that. Like, we didn't understand that. I said, well, that's not for you to understand. I apologize. I didn't explain that, but I certainly didn't want you to leave here and feel like I was blowing you off. I want you to know that, like, I made a thoughtful decision. And when you said that you all felt like I was blowing you off, like, at the end of, that's not what I want you to leave here. And I sat down and explained that. Now, I'm going to be honest. Like, have I had days where I wasn't my best self? I have. Because dealing with my own trauma or whatever. But I think all of my patients, most of them would say, Dr. Lockhart took the time. And when I was feeling like, I need more answers, I did that. And the reality is it takes more time. And so that's not physicians' fault necessarily. I think there's also a misunderstanding that how much control we often have over what our days look like. And so people are like, oh, doctors just want to get money. We don't have a lot of control over, like, if it's 20 minutes, 15, 10, unless you're in a private practice. And so, but that's what it looks like, not getting offended and getting an ego and recognizing, oh my goodness, like, I have a family who's come here or a patient who's come here for help from me. And what they're telling me right now is they have not felt like I've helped them. It doesn't matter if I feel like I've done everything under the sun. I need to take a moment and figure out what's going on to repair that, because they've come to me for help. And I need to make sure that they feel, that that's happened when they leave here. And that, to me, is what it looks like to be trauma informed. What happens far too often is that ego comes in and people are offended because they're being questioned. And I'm like, this is a partnership. I'm not, your mother, your father, telling you what to do. I am, for pediatricians, your child better than I do. You're with them 24/7, 365 days a week. I'm seeing them for a 20-minute visit. And so we partner together to do this. And if something doesn't make sense, you don't feel right about something, you tell me. And my patients, by and large, felt comfortable to say that. Like, I would sometimes fall into the habit of using doctor speak. I try not to do that. And I'm like, does that make sense? And they'll be like, no, Dr. Lockhart, that does not make sense. And I'm like, what's such and such, and I'm like, oh, I'm sorry, And so that's, trauma informed. And I say it's trauma informed because people are like, how is that trauma? Because Black folks are so used to coming into the medical system and being disregarded. And so we often enter the medical system prepared for that, on guard, and it can be challenging to hear, what people are telling us, or not, be sure that people have our best interest at heart. And so that's not necessarily our fault. This is, people talk about Tuskegee. This is going on today. That study that was talked about yesterday. And so the healthcare system has to work on being trustworthy, work on healing the trauma that's happened to Black people. And it's the foundation of diversity, equity, and inclusion, being trauma informed. And if you don't start there, for any marginalized group, it'll be hard to be effectively, taking care of them, I think.
Okay. I like that. Thank you. I think that's a great place to end.
So
Yes.
ask questions, and and they, clinicians should be ready to answer those, in a way that patients can understand. So thank you guys so much for having me. I enjoyed being here.
Thank you. I enjoyed all the information. I know that I've been getting texts and calls, or not calls, but I see some of the comments in the chat, and people have found this to be very useful. So keep doing your work. And you have that testimony. You're on the other side of the hill now. So
trusting God to, really to lead me where I feel like He's been telling me for a while, this direction. And I've been like, but no. And He's like, this direction. I'm like, okay. And it's been going well. So I feel blessed.
Okay.
So thank you for having me.
All right.
Thank you so much. Thank you so much. It's just been really, really great. Really, really great information.
Thank you.
All right, Dr. Lockhart, do you want to share where people can reach you, or is there anything else that you'd like to add?
I don't have a social media. I'm on Twitter, but I don't know how long I'm going to be on there. I'm just going to be honest with you. So you can find me on Twitter right now, and I'm probably going to be leaving there soon. But for now, I'm a twin_doc, and I'll figure out where I'm going to relocate.
Okay.
Because I don't have a professional like Instagram or anything else.
You have to share.
But my Instagram is my professional Instagram, so it's my physician one. It says twin doc, but it's my professional one, and so you'll see Dr. Kerri is my handle. So you can find me on there. Twin_doc.
Okay, awesome. So you have to find Dr. Kerri there on Instagram, twin_.
No, on Twitter.
On Twitter, I'm sorry.
Yeah.
All right. All right. Thank you all so much. Bye, Dr. Lockhart.
Thank you so much.
Cousin Kerri. My cousin.
Yes.
I have to say that. I'm
great show. You guys are doing a good job. Cousin Ashley.
Thank you. Thank
Miss
you.
Jova. Did I say it right, Miss Jova?
Yeah.
You did. And please continue your journey in trauma-informed care. Like, as a counselor, as a therapist, I always love to hear it from other mental health care providers. I appreciate you so much.
Thank you. It's just great to be here. So
all right.
Have a good night.
Those of you who are not subscribed already, go ahead, hit that like button and the subscribe button. Share our channel, because we talk about different things, and I believe that it can be impactful in a positive way to many other young women out there. So go ahead, hit the subscribe button, share it with a friend through text, on Facebook. You can watch this stream immediately on YouTube as soon as it's over. And we upload videos throughout the week. So if you subscribe, hit the notifications button, you will stay up to date about what we're doing right here in the ladies' room.
Absolutely.
Good night.